So thank you, Donna, for introducing myself and Nicola. So we both work for the Cancer Screening Unit, and we're responsible for looking after the Queensland elements of the implementation of the new National Cervical Screening Program. I will interject between Renewal. It's actually called Renewal. I might call it a change program or whatever, but that's basically what we're talking about. So what we're going to do in the next 20 minutes is give you a bit of an overview of the National Cervical Screening Program, and the main focus will be looking at some of the policy changes and what this means for health professionals and for women. We also want to share with you some of the timeframes and the implications for you, and also we'll finish off with the key communication messages that we want to start conveying to women and health professionals. We won't be covering the facts and figures about cervical cancer, basically because we don't have enough time. And obviously we're more than happy to take questions at the end of the session. But just to let you know that Nicola and I both aren't clinicians. We're pretty much program and registry members of the team. So if we can't answer your question, we will take it on notice for you. So for those of you who aren't aware, from 1 May 2017, there will be changes to the National Cervical Screening Program to reflect best practice screening. The screening program has actually been running for 24 years, so we're actually working and running in quite a changed environment at the moment. So we know that we've got improved knowledge about the natural history of cervical cancer. We know that there's new evidence about the screening age and the age range and the intervals. There's also new tests such as liquid-based cytology and HPV DNA testing. And there's obviously the new HPV vaccine that came out in 2007 for girls and boys. So let me just take you to the next one. So what I want to start off with is just give you a bit of an overview of the objectives of the Renewal program. So basically it was undertaken to ensure that women continue to have access to a screening program that's based on current evidence that's safe, acceptable, efficient and effective. So it goes back quite a while. Around 2011, a renewal project plan was approved by the Commonwealth, and then a project oversight committee called the Standing Committee on Screening, which is basically called SCOSE, and they report to the Australian Health Ministers Advisory Council. And our representative on SCOSE is Dr. Jeanette Young, our Chief Health Officer. So the objective of the renewal were to assess the evidence for screening tests and pathways, the screening interval, age range and commencement for both vaccinated and non-vaccinated women, determine a cost-effective screening pathway and program model, and investigate options for improved national data collection systems and registry functions to enable policy planning, service delivery and quality management. And one of the key things obviously is to assess the feasibility and acceptability of the renewed program. So the next slide is really about what are the significant changes that are currently happening to lead to the implementation in 2017. So basically, I think around 2013, the evidence and economic reports were presented again to the Commonwealth, and final recommendations were made in 2014 that a new cervical screening program and tests should replace the current program. So the main changes, there's 5 significant changes for us, is 2 yearly PAP tests will be replaced with 5 yearly human papillomavirus or HPV testing of samples with partial HPV genotyping. The entry age for the screening program will increase from 18 to 25 years of age. Women will be invited and reminded until they're 69, and then communications will be sent to them between the ages of 70 and 74, depending where they are on the screening management pathway. And one of the interesting changes here is there will be a self-collection of HPV sample for women who are under-screened or never screened. It will be an option for them, but it has to be facilitated by a medical or nurse or health practitioner who's involved in mainstream cervical screening. This message is the one that Nicola and I will be reiterating through this presentation. So until the 1st of May, it's business as usual for health practitioners and for women. So women aged 18 to 69 should continue to have 2 yearly PAP tests. So the next few slides, I'm going to talk a little bit about what HPV is and what the test is, and I'm just reminding you that we're not clinicians, so this information we've got from the Commonwealth, and I have got another handout actually that's been sent out to GPs. Evidence-based practice in there about HPV and testing. So HPV is a virus. It's a very common cause of infection, and it's similar to the common cold. Most women will get it at some point in their lives, and there's many types of HPV infections, and most of them clear up by themselves without causing any problems. It's transmitted through sexual activity, and it's very common in young women and young men in the early years of sexual activity. And the infections are transient, and they will usually clear up within 1 to 2 years. It's the virus that causes about 99% of cervical cancer. However, the vaccine protects against the most common strains of HPV, accounting for approximately 70% of cervical cancers. The infection can persist, however, in up to 10% of women, leading to cervical CIN and progression to cervical cancer over 10 to 15 years. So by screening women for HPV infection, those at high risk of cervical cancer can be identified earlier to enable closer monitoring for cytology changes that precede invasive cervical cancer. So this is the real difference between the Pap test and the HPV test. So what actually is the HPV test? So basically, screening women for the HPV infection has greater sensitivity of detection for high-grade CIN compared to cytology alone. The test provides 60 to 70% greater protection against invasive cervical cancers compared to cytology. The use of reflex liquid-based cytology improves the specificity of the new screening-based program. And HPV genotyping will identify women who have been infected with the highest risk of HPV genotypes. So this is the information I think that you've pretty much got on your slide now, is that the procedure for collecting the sample is the same procedure for having a Pap test. The women won't know much difference to the test. If HPV is found, which is obviously a positive test, further testing would automatically be done on the same sample to check if abnormal cells are present, which happens with the Pap test. Women who test positive for either of the 2 HPV types, most frequently found in cervical cancer in Australia, which is just type 16 and 18, will be referred for further testing, such as a colposcopy. And if a woman doesn't have the virus, she'll be invited to rescreen in 5 years. So one of the big policy changes, and this is going to be an issue for women, is screening women over the age of 25 as opposed to the 18 and up. So it's now understood that women under 25 years risk overdiagnosis and overtreatment in the current screening program, and this is due to the high prevalence of HPV infection in this group. While many young women may have HPV infection and associated cervical abnormalities, the incidence of and mortality from cervical cancer in this age group is low. There's no evidence to suggest screening women under 25 years is effective or leads to reduced mortality from cervical cancer. So that's going to be an interesting message to get across to women. And basically what we're saying that until any changes are implemented, women younger than 25 years can discuss their individual circumstances with their Pap test provider prior to making a decision to screen. So what does this change in policy and program mean for women? I've already touched on a couple of these. The procedure for collecting the sample is unchanged. We're using the cytology testing is automatically undertaken if the sample to check abnormal cells are present. It's about earlier detection now, who are at higher risk, and they can be monitored more closely and treated when necessary. Being vaccinated doesn't exclude women from the program, as the vaccine doesn't protect against all types of HPV that cause cervical cancer. And we know that some women who don't participate in the cervical screening program for cultural, religious or geographical reasons And as I've mentioned, we will be looking at a self-collection option. And this option is important because it's estimated that 50% of cervical cancers occur in women who have never been screened, and that another 28% develop among women who have waited longer than the recommended 2 years for screening. The number of total screens or tests, will be 9 or 10 instead of 26 over a woman's lifetime, and that it's estimated that at least 15% reduction in incidence and mortality for both HPV vaccinated and unvaccinated women. So there's some real significant benefits there for women. I'm going to hand you over to Nicola, who's going to talk to you a little bit about the changes to the register. You can just press that one.
So, yes, as Nikki said, I'm Nicola. I'm from the Queensland Pap smear register. So hopefully you've all heard of us, but for those who haven't, Donna will have our contact details, and we're a central registry of all Pap smear related histology and HPV DNA tests. So you're able to contact us for a woman's screening history. We can give you the date of her last Pap smear over the phone. And for any of you who are, obviously Queensland Health employees and nurse Pap smear providers, there is an online inquiry available, so you can contact me for the forms for that, and then you're able to log in through Queps and access those screening histories as well, which is a lot more convenient. So as part of the renewal, there's a tender process underway for a national cancer screening register. So that will incorporate Pap and bowel screening. There's currently 8 state and territory Pap smear registers operating in Australia, and there is recognition that there'll be efficiencies with one national register. Currently, Queensland specifically has a lot of cross-border issues, so with women who live in sort of Tweed Heads or even Northern Territory, also women travelling interstate who have their Pap smear whilst they're away on holidays or visiting families, and it gets sent to that state or territory's register, so that has been identified. So our register started in 1999, so this is a big change for us as well. However, we do see it as a positive because this register will be able to invite women to screen. So we're currently a backup reminder service. So whilst we remind women they're overdue, the national... Just pop your mute button on, please. Thank you. So the National Register will also invite women to screen when they're due, so they'll run against different databases to send out that information. It also looks like it will have options for women for how they want to receive their communication, so there's certainly benefits for women there. So the National Cancer Screening Register is progressing. The tender closed in October, and all those tenders are now being evaluated by specialist committees, and that's due at this stage to be done by the end of December. Then there'll be approval processes, transition and implementation, which will occur between approximately February 2016 and go live date, we're being told, of May 2017. So there's still a lot to be done before now, but the states and territories are certainly involved in the co-design of that register. And then the successful tenderer will work with the state and territory registers in relation to the design of the register, the data migration and any reporting as well. Thank you.
Thank you. Okay, so I'm just going to talk a little bit about the who and the how, just to give you a kind of feel for some of the policy, the breadth of the policy that is actually taking place to support the transition and implementation of this. So there is a comprehensive governance system that sits behind the renewal, which you would obviously expect. So I've already mentioned the Standing Committee on Screening that reports to RMAC, and RMAC then obviously reports to the COAG Health Council. There's also a National Programme Management Committee, which I sit on, and there's also a National Quality and Safety and Monitoring Committee, which another member of our team sits on one of the subgroups. So there's a range of committees and subgroups responsible for the development of policies and guidelines to inform the renewal. and whole breadth of membership. Obviously, you've got government representatives, you've got consumer representatives, but obviously you've got all the experts across all the fields that are relevant in cervical cancer. So some of the policies and guidelines currently being progressed, just to give you the breadth of this, and it's kind of quite interesting because you just got to think about how they all get there at the same time in order for we go for 1 May implementation date. So one of the most important things that obviously we're all waiting for is the new clinical management guidelines, because obviously the clinical management is going to be quite different with the HPV, and that's being led by the Cancer Council Australia, and I think we're looking for a draft around the February mark, which states and territories will be involved in having input into that. We also have a cervical screening program legislation agenda, so you can just imagine 8 states and territories and a national government with regard to privacy and confidential issues with data migration of all women's records. We have a transitioning women policy, so how do we manage women under 25 who are currently in the management pathway? We have a HPV self-selection policy and eligibility criteria. We talked about that option for our under-screeners and non-screeners. We have a conversation and discussion and guidelines currently being developed around credentialing or accreditation. We know we've got a strong program in Queensland, in WA, but we need to develop nationally consistent approach to credentialing of non-medical Pap test providers. So we'll be looking at training, professional development, because it differs across all of the states and territories. Then we've got the whole pathology scene. So we've got pathology standards being developed by the National Pathology Accreditation Advisory Council, MBS delisting and development of new items, and then a whole workforce strategy. We're looking at workforce and practice changes. We know that there's got to be training support, but we also know that the cytology workforce will reduce quite significantly as part of this process. So it's looking at retraining options for those professionals. And then the last one is the stakeholder engagement and communication. So the Commonwealth are pretty much leading this, but Queensland will obviously be part of that process. But it's trying to work out, when is it too early to have conversations with women about these changes without alarming them and making sure that they continue to have their two-year PAP tests. So you can see there's an absolute suite of policies, and we're only 16 months away from implementation date. So the last few slides I just wanted to finish off with you is some of the key messages that we need to start conveying to women and to health professionals. And there's another subcommittee that sits under the National Program Managers Committee, and that's the Communication and Participation Group, and I also sit on that one. And we've developed some key messages for women and for health professionals, and they've been endorsed by the Commonwealth. So these are the messages that you need to be giving to clients. So basically, pretty obvious considering what I've just been talking about through my presentation, is that women don't delay your Pap test. If you're between 18 and 69 and you've been sexually active, you need to have your Pap test every 2 years, even if you've had a vaccine. The cervical cancer is one of the most preventable cancers, and that there will be no changes to the national program before 2017. So, there's 3 or 4 key messages that we need to be thinking about for women. And for health professionals, exactly the same, slight flip side, business as usual till 1 May. Maintain your current screening program until the changes are implemented. Don't delay screening of women for their 2-year Pap tests, and remind women that even if they've been vaccinated, they still need to be screened. So quite logical messages. So that they're the messages that we do need to give women. And I know Nicola's already receiving calls about, I've got my Pap test due, should I wait, and all that kind of stuff. So the message is really clear, keep going until 2017. So the final slide then is for us as the cancer screening unit, what next? So we're obviously going to continue our active participation in our national working groups and our committees. We have been tasked with developing a Queensland implementation plan, which will look at communication as well, and we're hoping to have that available around June next year. So that will I suppose outline all the tasks and activities and strategies that we as a unit are responsible for implementing this renewal in Queensland. We will obviously continue informing our partners and stakeholders. That's part of our stakeholder engagement. And we did set up a Queensland renewal working group, which Jo is on. We had our first meeting about a month ago. And the aim of that really is it's clinicians and experts working in cervical screening and that. And it's basically to help the cancer screening unit implement changes to the national program. But something I would like to just suggest is that if you're interested, if you can give Donna your details, we are pulling together a stakeholder engagement list, and I'd really like to be able to send you information, comms information or messaging or whatever it is that we get from the Commonwealth that we think our stakeholders and partners need. It'd be really interesting to have your details if you want them, so we can add you to our email list. So I just put a couple of contacts down there. So you've got the cancer screening one, which is the national one. You've got the email to the renewal team. And then the last one is actually about mine and Nicola's contact details.